So with the YouTube live stream, can people come on and ask questions? Oh, all right. Testing. Testing. Okay. Right. We're going to start the meeting. Good morning, everyone. Good morning. Thanks for coming. I'm Dr. Dattoli, and this is the Prostate Cafe, where we talk about everything prostate. So I have encouraged you to bring your questions, and so I'll be happy to answer them. Would anyone like to start? Yes, sir.
So each routine for the prostate is individualized, is that correct?
Could you
Each regimen of radiation is individualized, or are they basically all the same? As far as the amount of radiation you get?
Are you referring individualized from this cancer center to other places?
No, in this cancer center per person, is it individualized?
Okay, yeah. So the question is the treatment here individualized per patient? The answer to that is absolutely yes. So no two patients will get the same dose. Okay, and we kind of go above and beyond what most places do. And for example, as it pertains to radiation, most centers that deliver radiation will give a uniform dose to the prostate. And typically uniform doses to the lymph nodes, if that's an area that's of concern or to be treated. In contrast, we do things differently here. We use MRI fusion and especially three-dimensional color flow Doppler ultrasounds to better delineate exactly where tumors are so that we can hyperdose select areas which are malignant and that we know are malignant with both the external radiation, which we refer to as DART, as well as with brachytherapy, also known as seed implantation. So each one of those is directed specifically per patient. And within the prostate itself, we will still give the entire gland a uniform dose, which is typically a dose that will sterilize microscopic disease. Now, the reason for that is we know that there's only so much that we can see with our imaging technologies, be it MRI or especially 3D Doppler ultrasounds, and there may be hiding some other cancers, in the prostate stroma that just haven't gotten big enough to show themselves with imaging. And based on that, we feel it's necessary to treat the entire gland to a microscopic dose level and boost select areas within the prostate to higher dose levels to eradicate tumors. Yes, sir.
At what point on the PSA level do you start treatment?
So the gentleman was asking about what PSA level do we start treatment. Well, that again is patient independent. So everyone's different, and the reason that it's different is there's something we call PSA kinetics. So for example, normal prostate cells make PSA, okay? And because of that, typically, not always, but as the prostate gets larger, as we get older, the PSAs ordinarily do go up, okay? And however, when they do go up, they typically go up slowly, okay? And sometimes plateau at a certain level. In contrast, cancers are basically uncontrolled cellular growth. It's makes cancers unique, and they basically just take it off, but they're still starting with the parent cell, in this case, the prostate cell. So again, prostate cells make PSA, if you make those prostate cells grow with uncontrolled growth, then you get a higher PSA. But there's some changes there too, and I'll get into that in a moment. But it's actually the rate of the rise that's more important than the absolute number. So for example, if a patient has a PSA increasing, we often hear that number being greater than 4 is important with a PSA. And let's just say that over time, a PSA goes from 4, to 4.5 to 5, and it's already over 4 and it's gotten everyone's attention. However, if a PSA was 0.5 and it went to 1.5 and then it went to 3.5, that gets our attention because the PSA kinetics suggests that there's something going on above and beyond the normal prostate growth. Okay, so it's not the total number, and I can tell you that I treat men with low PSAs, not because they were identified to have prostate cancer because their PSAs were high. But in those cases, often we find they're being identified because they're now having symptoms. The interesting side note on that is that, again, prostate cells are making PSA. It becomes cancerous, it makes more PSA, and the PSA goes up, with a few exceptions though. If the cancer is mutated, what happens, you see, is it loses its resemblance to the parent prostate cell. So it doesn't resemble it at all. So we start hearing about Gleason score tumors, which is a ranking of how aggressive a cancer can be. Well, at a Gleason score 6, prostate cancer cells are making a fair amount of PSA. As they become a 7, less PSA. As they get to 8 or 9 or 10, sometimes they don't make PSA at all because, again, they don't even resemble the parent prostate cell anymore. And that's a word of caution because, there are treatments and non-treatments. And one of the non-treatments is called active surveillance. And I do plenty of that. And what it basically means is that we've identified through biopsy a fairly low volume and low risk prostate cancer. But what we would expect with that low volume, low grade prostate cancer is that the PSA should be going up. And it typically goes up in a linear fashion. And that's expected because, again, we didn't do anything to the cancer, we're just watching it. However, if the PSA is going up, and let's just say it's going from a 6 to a 7 to an 8, and then starts going the other way, it starts going back to a 7 or a 6. And people will say, I spoke to a gentleman yesterday, and he told me a story, and basically said, well, I was really heartened because my PSA was going down, and I had changed my diet, and I was doing all the right things with exercise and all the prostate healthy things. But guess what? He ended up having a really aggressive Gleason 9 tumor. Okay, and that's the reason why, because it's suddenly mutated and it's not making the PSA at all, so it started going down. And that's a word of caution because I don't know if certainly it's been in the literature published, but not every urologist or oncologist knows that. I live and breathe prostate cancer, as many of you know, and I've done thousands of biopsies, and I follow patients, here and elsewhere, and I found that to be the case. So that gets my attention more than a PSA rise that's going up linearly if it starts going down. Sometimes it could, sometimes, with low-grade tumors, with good diet and healthy, living, you could potentially cause it to plateau a little bit, but it actually shouldn't go down. It should plateau a little bit. Yes,
Someone
sir.
on the live stream's asking, DART or brachytherapy, what am I a candidate for, and how do I know which one is right for me?
Mm-hmm. So the question is, DART, brachytherapy, which one? Well, that was something that I figured out a long time ago, and the reason I did was because I was doing surgery of the prostate, and I couldn't help to note that there was a PSA failure rate after surgery. We're all told, or you're told, by the urologist that just take it out, you're one and done, and that's the way it is. And, you may get the complications from the surgery, but it's over with. You have to do anything else. Not the case at all. And I came to find out it's not the case. And what I identified was that, many people, the PSA start rising again. At first glance, I said, well, I noticed the procedure is bloody, and it might be because of dispersion of the cancer elsewhere in the body, liver, lungs, bones, wherever. And that was my initial take on it. But I also thought the complications were pretty severe, and I wanted to do other things. So I started doing, and I was pretty much on the ground floor of this type of treatment called brachytherapy, where you actually put these tiny little radioactive materials right into the tumor. And I was doing those as a solo treatment. And, at first I thought it was wonderful because I knew that doing a radical prostatectomy would take 2.5 hours with a scalpel and would remove the internal sphincter, rendering a person incontinent or having leakage for a lifetime. And of course, the prostate's a sexual organ, so that's gone too. I had expected that, but I didn't expect the PSA failures. Well, I started doing brachytherapy, and what would take me 2.5 hours with a scalpel with surgery, I could get done in 15 to 20 minutes and not use a scalpel. And there was no cutting, and we had minimal blood loss, so the concerns of spreading cancer weren't so important. And from a perspective of side effects, well, we didn't touch a sphincter, and we're leaving the prostate alone so sexual function can happen. And that was a home run. I had the largest series in the world in New York City at a hospital called Memorial Sloan Kettering Cancer Center. And what started to happen was the PSA started rising again. At that point, I scratched my head, and I didn't quite know why, but I spent a good amount of time in the surgical pathology lab, and I came to find an interesting caveat about the prostate. So the prostate gland is shaped something like this. And this is the bottom. We call the bottom the apex. We call the top the base. The base is bigger than the apex. Upside down, we often think of apices as the top and the base the bottom. But anyhow, and of course, the prostate is segued into the right and left side. Most prostate cancers, they begin on the edge, and we call this the peripheral zone. And if you review your own pathology, you'll see probably it came from the peripheral zone. They'll say left apex, left base, wherever, but it's typically arising in the peripheral zone. Well, when I was reviewing whole mount prostates, meaning looking at the entire gland with a microscope at the sides, I came to find an interesting finding, and that was that the prostate has no capsule. And that's really important because most cancers have capsules, and most organs have capsules. Yeah. Even in the urinary system, the testicles, the penis has a capsule. The prostate has none. That's the way we were made. And the reason why that's so important is while this is the tumor, the microscopic elements, I often talk about spiders, will easily grow into the fibrous tissue inside the gland, but they can also easily grow out. And I came to realize the big problem that I was seeing both when I had done surgery, because when you do surgery, you're basically just carving out the prostate, but you see you're leaving these behind. And when you're doing brachytherapy, you're putting these tiny little dots into the gland, but you're not addressing the outskirts. And the outskirts are really, really important because, again, the prostate has no capsule. The cancer begins right on the edge. And the other definition of cancer, by the way, I've talked about uncontrolled growth of cells. The other thing cancers do is they invade surrounding tissues, and they typically do that microscopically. And because of that phenomenon, even with brachytherapy, as good as it was, we're not addressing this. And there's another element that makes the prostate interesting. There are these organs in our bodies that we call lymph nodes. And we have more lymph nodes in our bodies than we have vessels. And lymph nodes are in our bodies specifically to remove things that are not supposed to be there. And, generally speaking, they're filters. They're removing debris. If we have an infection, they're going to remove the infection and get rid of it. But when there's cancer, they see cancer as being foreign, so they remove it right away. And it just so happens that the prostate has lots and lots of lymph nodes all the way around it. And those lymph nodes quickly grab up the cancer. And so I came to the understanding that, okay, the prostate, it begins inside the gland, but a lot of it is actually outside the gland, and we need to address the bigger picture, and that's the outskirts. And the two areas, by the way, which are very, very rich in lymphatics, has to do with prostate in men and the breast in women. And they're really similar organs in many ways, how they're influenced by hormones. You know, the women it's estrogen, the man it's testosterone. But anyhow, I came to the recognition that I better treat these lymph nodes, and I better treat this migration into the lymph nodes. Otherwise, I'm going to leave cells behind. So based on that, I realized that I just had to give some version of external beam radiation to do that, and that's what we did. And I was at a place where we really modernized the external beam radiation to be able to treat these lymph nodes and the prostate very accurately and precisely, and we've never stopped pushing the envelope here to accomplish that. So frankly, I rarely, if ever, do brachytherapy alone for that reason. I just think that it accomplishes the exact same thing with surgery, but in more cases than not, you're leaving microscopic elements behind, and it's insufficient. So that's my position on it. So I became a big proponent of the so-called combined modality regimen, where you combine a version of external beam radiation with the seed implants, if possible. Not everyone can have it, but if possible. And if you look at data, and I've published a lot on the combined modality approach, the data is superior to solo brachytherapy. And for that matter, solo external beam radiation. There's a large study ongoing right now. It's called the Ascend-RT trial. And while I've published a lot on combined modality regimens, and I know others in the field have published as well, this Ascend-RT trial is ongoing. It's a compilation of about 30 institutions in North America, and they've been accruing data. And what they've been doing is looking at external beam alone versus the combined regimen of external beam and brachytherapy. And they're finding what I found, and that is about a 15 to 20% survival advantage with the combined approach with external beam and brachytherapy. So that's a big number. If you're one of the 20%, it's a really, really big number. Now, we do DART alone, but I try to sub-select my patients for that. If I give you an option for it, it's probably because I feel we could get the job done with DART alone. Okay, that the volume is not high, so high that we can't do it. Okay, and then there's the person who just doesn't want to have brachytherapy, even though I tell them it's minimally invasive and there's no blood dispersion or anything like that. They still don't want it. It's a procedure and they don't want it. And so in that case, we do it. And with our DART, we can give higher dose levels. And so what I haven't done here is to compare contemporary radiation using DART to the combined modality approach, DART and brachytherapy, where I have really long-term data on the combined approach with DART and brachytherapy. Yes, sir?
Could you describe, I read part of your book, and you described like two types of biopsies, transrectal ultrasound and transperineal. Could you describe those, the differences, and when would one be recommended versus the other?
Okay, so this gentleman is asking about the different approaches to do a biopsy, which is typically the first thing that has to be done to determine if you even have prostate cancer in the first place. So most biopsies, it could be as high as 9%, 99.9% of patients who have prostate biopsies have it done through the rectal route. It's called transrectal ultrasound guided biopsies. And it's just as it sounds, you're going through the rectum. Now, the other one, by the way, is called transperineal prostate biopsies, which means you're going through an area we call the perineum. So if we were to look at a side view of the prostate, right, it'll look something like this, and the rectum, or again, we're looking from the side, the rectum is on the side of the prostate, okay, and it comes down like this, and here's the anus right here. There are appendages off the prostate that we call seminal vesicles, and they kind of right around here. The prostate urethra goes like this, and it empties into the bladder, which sits like that. Well, transrectal biopsy is the one that's done, throughout the fruited plane, and as I say, 99.9% of the time, has to go through the rectum. And what you do is you put a probe in the rectum, and through that probe, you visualize with ultrasound the prostate, and then you find the area that you want to biopsy, and the probe itself shoots out a little needle, and the needles go into the prostate, and that's how it's done. One of the major problems with that is, but what if there's a cancer over here? That becomes a problem because the needle is only so large, and if you have an enlarged prostate, that becomes a problem. Okay, so you might not be able to get to the cancer in the first place. So that's a problem. And then you end up getting a negative biopsy. It came back, good news, everything's benign, but you missed the areas where cancers may be living. The other problem, which I think is a big problem with transrectal prostate biopsies, is the fact that the rectal wall obviously carries a lot of bacteria. And when we do surgical procedures, we sterilize areas. If you've ever had a surgical procedure, wherever you're going in, whether it's an appendix or gallbladder, wherever, the skin is going to be anesthetized with betadine and other, antibacterial agents. Well, you just can't scrub down the rectum. You just can't do it. So, you do your best with Fleet's enemas and you'll purge your bowel and all those kinds of things. But the fact of the matter is, you got to go through the rectum and you got to introduce bacteria into the prostate 100% of the time. Now, what does that mean? Well, there's a potential for infection. Is it 100% infection? No. Okay, we don't all get COVID if there's someone who's got COVID or influenza, but maybe 15% of us do. Okay, and that's pretty much the rate. Because if you look at transrectal prostate biopsies, approximately 15% of the patients do end up in a urgent care or an emergency room within 36 to 48 hours with an infection. 5% of them actually end up in the ICU because typically you are introducing bacteria. The bacteria can get into the urethra and then in the bladder. So the most common situation is a urinary tract infection. However, it can get into the bloodstream, and that's the reason why the patients end up in the ICU with a bloodborne infection, a bigger deal. So those are two big problems associated with prostate biopsies through the rectal route. The other problem has to do with the location of nerves. So the prostate does have lots of nerves, but they're small little nerves, okay? And the rectum, on the other hand, has really big nerves. The whole purpose of the rectum, its sensory process is to let you know when you have something down there to evacuate stool. Well, it's got big nerves, and you can't see nerves with the ultrasound, so you invariably nick the nerves. Now, I remember a time when transrectal biopsies were done without anesthesia at all, and that really smarts, and patients would be screaming with each and every snip. You all know we do, we don't just do one snip. You do many, and with each one there's pain. But the other problem can be that even when you have anesthesia, again, you've engaged some pretty big nerves, and you may have some pulsating, nerve pain, or just kind of throbs for a while. And I know, having done them that way, some people will have it for 2 to 3 weeks. That's a big deal. And then finally, just like there's big nerves in the rectal wall, there's also big vessels in the rectal wall, and you engage those. Now, again, the prostate has a lot of vessels in it too, and so there is potential bleeding in the prostate. However, the big ones are in the rectum, and when you engage them, there is a potential that if there's cancer being pulled out, that the big vessels are getting cancer in them, and those big vessels of the rectum communicate more widely with your circulation, your lungs, your liver, your bones. And, you might know someone who has, for example, a rectal cancer, and we're constantly looking to see, did it spread to the liver? Did it spread to the lungs? That's because that's where the circulation goes. So there is a body of data that suggests that when you do biopsies through the rectum, you can actually disperse cancer. It's a small number, but it's a real number, you know. So based on all of that, we do, or others will do, the transperineal approach. Now there's an area right here, and that's called the perineum. And here's the scrotal sac and then the penis. And so this area right here is skin, and we can betadine it. We can, you know, scrub it completely, just like any other surgical maneuver. So risks for infection are really small. And this picture here is a large picture, but we can also get to any location we want to in the prostate. There's nothing that, you know, I can't get to when doing a transperineal prostate biopsy. Also, you're not engaging the pain sensors in the rectum. Again, but there are nerves in the prostate, and so many men will say that they may have a little dull, minor pain associated with that procedure, but it's not significant, you know, and it just doesn't last for weeks. It lasts maybe for a day or two, if at all. I do a nerve block. So in addition to doing our procedures under what we call twilight anesthesia, which is the same as with a colonoscopy, I also do something called a pudendal and periprostatic nerve block. And I've been doing that for a long time. I'm actually going to publish on it this year. But anyhow, because it really does make a big difference. And finally, you're not engaging big vessels. So there can still be bleeding, but what happens is the blood goes into the urethra and then ends up in the bladder, and then you just pee it out. And it's a closed loop, and there's never been a single report of a patient who has transperineal prostate biopsies where cancer has been dispersed somewhere else. So for all those reasons, you know, I think, you know, transperineal approach is the smart way to go. As I say, the problem is not everyone's doing it, and a small percentage of doctors do it that way. And, you know, so sometimes you just have to have it done, have to bite the bullet and get a transrectal biopsy. Anyone else have a question?
Yeah, I do.
Okay.
Yeah, I wonder if you would expound on your surgical experience at Sloan Kettering. When I looked it up, it kind of said that the experience only was regarding the brachytherapy.
Right. So when I was in New York, both at New York University and Sloan Kettering, I had a great interest in surgical oncology. And I involved myself every which way and every chance I can get, doing different types of surgical maneuvers, all types, tongue, lung, brain, breast, gynecologic, I was involved with. And I came away with the knowledge that, of some of the principles of cancer when you remove it surgically. The very last site of the body they got involved with was the prostate. And Sloan Kettering was one of the very first centers in the United States or anywhere to do the Da Vinci robotic procedure. And it was led by Dr. Scardino and then Dr. Eastham. And so that's where I spent time at Sloan Kettering. At NYU, I had also done some other types of cancer operations, but I got a pretty good understanding of principles of surgical oncology. One of which is, by the way, when you do remove a cancer anywhere in the body, you really go out of your way to remove more than what you think is there. And for example, you know, this could be a tumor anywhere in your body. And it might look like a very well-defined tumor. It looks like a marble or a stone or a black spot or something like that. Or it may feel like a lump above the nodule. But we know that cancers don't just begin and end there. They tend to have, you know, elements invading the tissues around them. And it typically does that microscopically. Now, it could be a big cancer and invade macroscopically, but more commonly, it's a microscopic extension. I often talk about a spider with the legs being really thin or invisible, like a daddy long leg spider. But because of this principle, when you do remove a cancer surgically, you know, you realize this phenomenon. So you don't just remove this, you try to go wide. And that's how you do cancer operations wherever it may be. And, you know, you can appreciate if that's In the liver, you can take a chunk of the liver. If it's in the lungs, you can take a big chunk out of the lung, even a lobectomy. With colon cancer, it could be a very small tumor the size of, a grape, and you still remove about a foot of your bowel. Women who have breast cancer could be the size of a BB, but you still remove something the size of a lemon. You can't do that with the prostate. So again, prostate being like that, you have the prostate urethra going right down the center of it. Okay, and beneath the prostate, let me say this continues down, but right around here is the urogenital diaphragm. Right here is a very big sphincter that we refer to as the internal sphincter, which is actually part of the bladder, which is bigger. And between the prostate and the bladder are these appendages that we call seminal vesicles. So again, the prostate is a sexual organ. It's a G-spot in men. For those of you who don't know, it makes most of the ejaculate, we call it the seminal fluid. It has a lot to do with the orgasm, and it also has a lot of nerves, arteries, and veins that are heading off to the penis. And they're over to the side here. So what happens with the prostate is, again, you have this tumor here, and it's kind of going like this, and you just can't take a big swath around it. I mean, the best of worlds, you'd say, well, let me just take a big chunk like that. But if you did, you'd be removing part of your urogenital diaphragm below the prostate, where there's another group of sphincters right about here. You'd be removing the big nerve bundles that go to the penis. You'd have to remove this big sphincter here. So the way prostate surgery is done is you basically peel it off of surrounding structures. If you happen to know there's a cancer here, you might go wider. You try to go wider. You may have to take out that bundle of nerves. And then you kind of come around like this. And then you try to take out the seminal vesicles. You have to take out, you have to take out the big sphincter. So these are the reasons why with prostatectomy, radical prostatectomy by any route, whether it's Da Vinci or open, most men are going to suffer issues of leakage because you've taken out the big sphincter that is part of the bladder. And now you have to give all the work to external sphincters, which are very small compared to the big one. And, prostate cancer afflicts men in their later years. So muscles are getting weaker as each and every year goes by. And that muscle, even, for those guys who just spend a lot of time, trying to build a Kegel exercise and pelvic floor muscle exercises and biofeedback, working against the clock because muscles are getting weaker and weaker. So that tends to be a big issue with, leakage. And then the other issue has to do with, well, the prostate, again, is a sexual organ, but it's removed. There was a time, it was a very famous doctor at Johns Hopkins, and he pioneered the so-called nerve sparing procedure. And his name was Patrick Walsh, and I know him. And he was actually always sparing the nerve bundles around the gland, so he would never go wide. He just had to spare those nerve sparing. And it became popularized for a while. But then what started happening is everyone looking at his data, we started seeing a fairly high failure rate, with PSA failures and, picking up cancer in the region. And it had to do with that perhaps, by sparing the nerves, you're sparing the cancer. And it kind of got a bad reputation. And, they started calling it a cancer sparing procedure. Oncologists did, and so that's kind of the, what became of that. And I know there's a few doctors right now trying to revisit that, reinvent the wheel. Same thing is going to happen, where cancer failure rates are going to, start going up and up and up again after getting the so-called nerve sparing procedure. Prostatectomy.
Can I just do a follow-up?
Yes, sir.
So let's say males' PSA is gradually gone up, and PSA levels suggest that further investigation is warranted. Is there a step between the PSA test and a biopsy that would be the first diagnostic step, or would it be a biopsy?
So he's asking if PSA rises, and maybe we deem it to be suspicious for malignancy, do you just go right to the biopsy? And I would say you could, but I don't do it that way. I always recommend a multiparametric MRI. So MRIs have gotten really good at defining what's going on with prostate cancer and whether it needs to be biopsied at all. So, 10 years ago, radiologists were somewhat crude in their ability to look at a prostate image on MRI and say, oh, there's a cancer. They weren't so sure. They'd say, I think there's a cancer. But the reason why that was the case is because the prostate area moves around a lot. So it's a moving area, and it moves because everything around it is moving. The rectum is pulsating and moving, the bladder is pulsating, and the diaphragm is pulsating. It's got small bowel, large bowel, and even some degree of pelvic breathing. It moves a lot. So they realized that if they can increase the strength of the magnet associated with MRI imaging of the prostate, that could change things, and it really did. It made a really big difference so that they're able to say, okay, there is a cancer there, okay? And then they've gotten so good lately by using what I referred to earlier, or just referred to multiparametric array. They're able to also say, there's a cancer, and we predict it's going to be this or that clinically aggressive. And they do use some AI now, but they have a scorecard that goes 1 to 5. It's called PIRADS scoring, PIRADS, 1 to 5. 5 being the most aggressive, so they're saying, you got a cancer, it's going to be aggressive. We predict that. Or 1 is the least aggressive. So 2 to 3 is kind of a gray area where you have to make other decisions. But anyhow, that's very valuable to urologists and oncologists before doing a biopsy. So I make sure that all my patients have had such a test. Now, if it's a 2 or a 3, there are some other tests that can be done, and we use something called a 4K score. And that helps you to kind of like decide, I'm going to do the biopsy or I'm not going to do a biopsy. We found that to be the most accurate marker. It's just a urine test, so there's no biopsies necessary. It's not even a blood draw. It's just a urine test. And that does give us information. But again, I don't need that if the MRI suggests that there's a tumor there and it's going to be clinically significant tumor, especially if it's a 4 or 5. Then we, say, okay, let's get you scheduled because you need a biopsy. Also, when we do biopsies, we fuse our technologies with the MRI. So we import the MRI images, and then we fuse it with our actual biopsy session. And that's important as well. So that's another reason why I do like to have the MRI. The problem, though, is that, you fused everything, and the MRI is showing you where the tumor likely is in an area inside the gland that you're going to biopsy, but then a patient moves. And like all bets are off. I mean, it's just like, wow, what are you going to do now? Well, here we do use a 3-dimensional color flow power Doppler ultrasound. And we really put a lot into the faith into that test. And I've published on it. There's an article over there, and it basically shows that if I think there's a cancer, about a 97% predictive accuracy if there's a cancer, that's with the 3D color Doppler ultrasound. So I can at least back up my data because I'm thinking, all right, the prostate tumor was supposed to be here or here or here, but now per MRI, but the area's moved. But that's okay. We can move the ultrasound with you. It's not so easy to move an MRI image. It's next to impossible. There are some places that actually do MRI guided biopsies, but it's not encouraged. It takes a long time. You all who've had MRIs know it takes a long time to do an MRI. So you can just imagine what happens, with each and every stick of the biopsy gun. You'll be there for hours. So we don't encourage it. Yes, sir.
4K test. What's the purpose of that if the MRI looks fairly clear?
Yeah, so if a person he's asking about the 4K score that I just mentioned. And what happens is if the PSA is showing kinetics that are suggestive of a cancer, okay, so that you get the MRI in the first place. But the MRI is kind of, we're not quite sure. It could be a 2, it could be a 3, a PIRADS 2 or 3. on a scale of 1 to 5, 5 being the most aggressive. It's in those specific patients, that's, group that has 2, 3 with a suspicious PSA, that we do recommend the 4K score. And it's just basically gives us it gives us more confidence that there's going to be cancer, because any procedure is a procedure. Even if it's a transperineal biopsy, it's still a procedure. We don't want to put you through it if we think there's a low yield associated with getting a cancer diagnosis. All right. Yes, sir.
Can you speak to the Barrigel implant that you use during treatment? Why you use it and what happens to it? Is there another process where you have to go and take it out, or does it dissolve?
Yeah, so this gentleman is asking about an item that we use called Barrigel. And there are many different types of agents that you could use. One was called a spacer. That was actually the first one. And basically what happens is, I showed you the side view of the prostate, and the fact that the rectum is right on it. Okay, and that could be the prostate or the prostate bed. It's just right on it. Okay, and so the purpose is to space the rectal wall away from the prostate area being treated. And as I say, there's different methods that could be done. One is called spacer. It's still done. The one that I use is Barrigel because it's deformable. I can put as much as I want in there. I can take my time doing it. And it does space very nicely. Meanwhile, it doesn't last forever, so it doesn't have to be taken out. It just is absorbed by your body over the course of several weeks to a few months. And we use it on virtually every patient here that's treated for their prostate cancer. There is an item that is being pushed right now. They're coming to ask me all the time, but I won't do it, where you actually have to do an incision into the perineum to inject, the spacing device, actually to put a balloon in there. I'm just not doing it, but I used to actually put hyaluronic acid and collagen into the area in people who had previously been treated with radiation. And I really want to make sure got no dose at all. But that was before the advent of these spacing devices, which are also called hydrogels, rectal hydrogels. But I think they have good purpose and utility, and we've been using them for as long as they've been available. And I was even using, as I say, the hyaluronic and collagen before they were available. I'm just going to take this one back here for a second, okay?
Doctor, once treatment is fully completed in the patient, how do you go about measuring the success of that treatment?
So how do you measure success after treatment? Well, it depends on what kind of treatment it is. So typically, in men who've had their prostates removed surgically, called radical prostatectomy, the gold standard is to just do PSA testing, recognizing that any small increment of PSA upwards should garner some attention from the urologist and oncologist, and that's based on data. The thinking also is that after radical prostatectomy, there's a fair amount of scar down that happens within the surgical field. We call it surgically denuded field. And so, the cancer can be growing, but it doesn't have a lot of access to the outskirts. And if it gets outside, it only a little gets outside. So any increase of PSA, so the current NCCN guidelines suggest that after radical prostatectomy, any 2 increments of PSA upwards beyond above the nadir. Nadir means as low as it's ever been. And in patients who've had their prostates removed surgically, it should be close to 0, or undetectable is what we call it. And then if there's 2 rises above, then a workup ensues. Sometimes you can't find it, but data suggests that the highest probability is that the tumor is in the area we call the prostate bed, okay? And that's what we refer to as the area of target after prostate removal, prostate bed. The fact is that, again, low PSAs mean a lot. So there we really apply our PSA kinetics. And we also, in that setting, do really believe we should be doing additional testing. Now, again, here we do three-dimensional color Doppler ultrasound, and that is our gold standard for picking up tumors directly in the prostate bed where you may otherwise not see it. You may not see it with an MRI. Okay, there's another test that's routinely being done now in the community called a PSMA PET scan, and we feel that's also necessary to best stage a person, because maybe even with a low PSA, the cancer has migrated to some other part of the body, and that becomes important too. So that's pretty much the staging that we do with any PSA rises, and there's a fair amount of data on that. A lot of guys get radical prostatectomy, and it's been tracked for a long time. And there was a time not that long ago where the magic number was 1.5, and the urologist would just wait until the number got to 1.5 or greater, and then send a patient to radiation. They started to find, well, I'm only curing about 30% of those patients, maybe. So the number has since been ratcheted down and down and down. And I would make the case that no matter what the value is, if it's a couple jumps above the nadir, the lowest it's ever been, you should be treated. And data suggests that 0.2 is a really important number. 0.2, not 2, 0.2 in a radical prostatectomy patient. And then surely it should be gotten between 0.2 and 0.4. And unfortunately, I often see patients and, the urologist or oncologist, just weren't paying attention. So it got a little higher than that. And, not to say you can't cure a patient whose PSA is 0.8 or 1 or 1.2 or 1.5 or 2.5. And I've cured patients with 6 or greater. But the yield goes down, the probability of curing goes down. So that's radical prostatectomy. And in patients who've had radiation treatments, we also, first, PSAs are rising. Part of the initial staging is to do a PSMA PET scan also to figure out where the cancer is. Then we treat all known sites of disease. And we have a fair amount of experience here where we actually will treat all known sites of disease, meaning more than just the prostate and more than just the lymph nodes which live outside the prostate, but maybe also some bony sites or lymph nodes that are distant from the actual prostate. And once treatment is done, we also value the PSA. We want it to get very low, if not undetectable as well. And then we also look at it from a three-dimensional color Doppler ultrasound again, because what we do have, in our base is we have your cancer on Doppler before we started. We know exactly where it was. We know exactly what it looked like. So what does it look like now? Okay, and after the whole treatment is over, we would expect to be nothing seen with a 3D color Doppler ultrasound. And that's our gold standard. Now, we also like to have light speed helical scans to look for things like lymph nodes and, did a patient develop some bony lesions? And prostate cancer likes to go to bone. So we look at everything. But those are the two things that we do here. I think most places in the country will primarily do not the Doppler ultrasound because they don't have it. There are a few places that have it. UCLA has it, New York has it, Munich, Germany has it. Not a lot of places do and have a lot of experience like we do or they do. But I think after radiation, they also, put their faith in the PSA rising, and then if it does, then doing tests like the PET scans, PSMA PET scans. Yes, sir.
What happens to the seed?
The seeds? Oh, so the seeds are made to be tissue compatible. So we put them in and we never take them out. We don't have to. They just become inert items and they don't interfere with anything. So, for those of you who, for example, you find you need a pacemaker or you need an MRI and they say, do you have any metallic parts in you? The answer is no, have nothing. And, they've been specifically made to be that way. So they never interfere with anything. In the very beginning, the only thing they'll interfere with is a Geiger counter when you turn up the volume. It'll let you know. But once the isotope is down to background level, then you don't pick up anything. You never have to take them out. There is another kind of brachytherapy called high dose rate brachytherapy, and I've done hundreds, probably in the between 1,000 and 2,000. I don't really like them because the isotope there tends to be very penetrating. But in that situation, as it states, temporary high dose rate brachytherapy, you put them in temporarily and then you pull it back out, and you repeat that over more than one time, and so then you do have nothing. You have nothing in you at all. The problem again is the isotopes I don't particularly like. They're very penetrating, and they could penetrate your whole body. And the whole purpose of brachytherapy is that to this day it is the most precise form of radiation. Nothing is as precise as brachytherapy. Not protons, not neutrons, not high energy photons. So the brachytherapy is very precise. So it kind of is not. It doesn't seem smart to me to do the high dose rate brachytherapy, since the isotope is very penetrating. I used to actually, when I was doing them, I used to have, when we did the treatment itself, I used to have the guys stare at their groins and then put lead shielded goggles on them so they wouldn't develop cataracts. That's how penetrating that isotope is. It's called iridium 192. I think I have a question here, and then I'll get back to you. Yes, sir.
The block that you put in, is that put in at the same time the seeds are, or is that two different procedures?
So he's asking about the block that I referred to earlier, and I do the blocks, paraprostatic blocks, accompany both the biopsies and when I do prostate brachytherapy, because it just numbs the nerves. And with each of those forms of therapy, the pain is going to be there primarily just as you do it, and then right afterwards.
No, I'm talking about the shield to prevent the radiation
Gel.
going into the
Gel.
heart.
Oh,
Is that
okay.
One
So,
procedure or two?
so
putting the
the
seeds
shield
in.
that I was referring
Right.
to, that this gentleman asked about, called Barrigel or
Right.
Spacor, it's a one-time procedure. It's done, and that's it. You don't do it more than one
No,
time.
the question is the Barrigel put in at the same time the seeds are, or is
Got
it
it.
two different procedures?
Got it. So I'm not sure what they do elsewhere. We do it as two separate procedures here. Okay, he's referring to the Barrigel and the timing and sequence, but we do it in a two-step way with brachytherapy, and we have our rationale for that. Primarily so the gel, while it's put in, and as I've told you, it does resorb. Your body gets rid of it. Okay. Well, if you just think about it, when you're doing brachytherapy, and again, I don't have the side view up here, but the rectal wall is direct contact with the prostate. They're like that. Okay. So we believe that's the best time to space. Okay, with brachytherapy cases. And again, because I don't want to do it in the very beginning and then have, let's just say 50%, 70%, 90% of the gel resorb. Then I do the brachytherapy. Well, then I don't have a good spacing. Whereas so we believe when brachytherapy is necessary, that's the most important time to do our spacing. And here we use Barrigel. In patients having radiation only, full course radiation, well then you'll get a tap from my staff and they'll say you're up for your Barrigel early on in the treatment course. If you have radical prostatectomy, you'll get it early on in the treatment course. Okay, because then we know that it's going to resorb, but it's not going to be resorbed until you're finished your treatment. So we try to time it appropriately for each case.
So I don't know if that answers my question. My question is the gel, when you're putting the seeds in, is the gel put in at the same time, or is it, you say that the gel is put in before?
So the gel is put in before.
Day before.
Before the seeds?
Day before.
Thank you.
Okay. I think this gentleman here was first.
What are the chances of getting bladder cancer after prostate cancer treatment?
So the question is secondary malignancies with prostate cancer. I follow my patients forever. I really do, and I don't see a lot of secondary malignancies. And The fact of the matter is there a slightly higher risk for bladder cancer in men who have prostate radiation? Yes. But is there a higher rate of bladder cancer in men who have no prostate radiation? Yes. So there's a phenomenon that we know, if you have developed one cancer, you're at higher risk for developing another cancer. Okay. And if you developed a cancer in the urogenital system, which is where the prostate lives, then you're also at risk for developing another cancer in that region. That could be the bladder, that could be the ureters, that could be the kidneys, that could be the penis. Okay, it's all part of the same organ system. So I know, historically they'll talk about that phenomenon and radiation carcinogenesis, but I'm not sold on it. I know there are many who aren't as well. We all believe that it's just that you've got a malignancy, you're at a higher risk for a secondary malignancy. And these are the reasons why we really do counsel you. Once you're finished treatment, we would like to get on a really good diet, a diet that is less carcinogenic, that's healthy for you and, deters cancers, because, you are at a higher risk. Then there's some men who have a really high risk because they harbor a mutation like BRCA1, BRCA2, or some other mutation that suggests that they could get another cancer in the urinary system or somewhere else, but especially in the urinary system. Yes, sir.
Why do some urologists with low-grade tumors recommend aggressive monitoring versus just go ahead and start therapy?
This gentleman's asking about something we call active surveillance, and why is it that urologists are recommending it? And I think it's overutilized. I think that we need to be really careful about it. And when I follow a patient with active surveillance, it's the patient who has 2 or less low-grade tumors defined as Gleason 6 with less than 30% involvement in each one of those biopsy specimens. That's who I would recommend. And then I follow them very closely. But, we've identified that, what you're basically doing is you are, kicking the can down. It's a matter of time before the cancer, grows and becomes a problem where you have to be treated. And, I'll never deny a man treatment if he wants to, even if he has one biopsy positive or low grade, just because, it is cancer and there's always potential for spread. I've treated a lot of men with low-grade tumors who are followed, and I believe not wisely, for just too long a period of time. And by the time they get to me, they have metastases with what they thought was a low-grade tumor. And so it could be troublesome. But I think that, they're expanding their guidelines. I'm always worried, what comes out of their May meeting. It's called the AUA, because they all sit down and they make these plans. And they say, okay, we're going to do this, and then, and then we're going to do biopsies once a year, we do MRIs once or twice a year, we do, and it becomes, a follow-up, issue where you're just spending a lot of time tracking down, and then you ultimately are treated. And then when you're ultimately treated, you say, well, gee, what was my potential for cure early on compared to now? And it's always going to be, earlier is better. But I also do active surveillance. It's just that when I do, I really watch my patients closely. Yes.
When the cancer has spread to the lymph nodes, especially the ones that are a little bit higher in the region, how are you able to know that the radiation treatment was sufficient once all of the treatment is done? Because of course, with the 3D Doppler, you can see that region, but you're not going to be able to see those lymph nodes.
Right.
How do you know that they are that those are actually have been eradicated?
Right. So she's asking about lymph nodes and how do we follow up on lymph nodes? It's a little more challenging because, as she also mentioned, we can follow up the prostate proper with a 3D color Doppler ultrasound. Lymph nodes are more difficult. So what we do here, first of all, we treat the lymph nodes that we know are affected. I usually go a little higher than the ones I know are affected. I treat them to a dose that I believe is eradicative and cure cancer in lymph nodes. And we have a long experience here, one of the longest in the country, treating lymph node disease. And then we do recommend periodic scanning. So we do light speed helical scans of the abdomen and pelvis to specifically track lymph nodes to see if there's anything enlarging, in the sites that we treated or above the site that we treated. Lymph nodes are always going up. So in other words, they start in your toes and they end up in your neck. And that's just the pattern of drainage of lymph nodes. So they typically go higher. So we're always looking higher. Are there any lymph nodes above the area we treated that are affected or getting larger? And if necessary, we'll do a more advanced imaging like the PET scans. Okay, they're telling me that I'll take one more question.
So, the prostate cancer, is it hereditary? And if it is, for the gentlemen who have sons, is there anything they can do to maybe ward it off or help prevent it?
Yes, so the question has to do with familial prostate cancer. So there's no question that if a first degree relative has prostate cancer, you're at higher risk, regardless of, other tests which might show that you are or are not. There's a link also between prostate cancer and breast and ovarian cancer. So that men who have prostate cancer need to alert their daughters that they're at a higher risk for developing breast or ovarian cancer. But then there's also familial links, and there are genetic markers that we do here that look specifically at a genome that might say, oh, you have the certain cancer mutations, and the most common ones are BRCA1, BRCA2, and another one called ATM. And those are powerful. They predict that you have a higher risk yourself. In men, I've treated many men with their prostate developing their own male breast cancers, but their daughters, their sons are at much higher risk of developing prostate cancers. And the only thing we can do is have them undergo periodic and frequent testing, of their prostates with more frequent PSA. And I generally recommend, if it's a true BRCA1, BRCA2, you begin screening with PSAs at age 35. Okay.
Just real quick, follow up for that. How often would you have blood work? Would you suggest it in that case? My brother's in for treatment now. He's 2 years older than me. I'm 65, and our uncle had it too.
Okay.
So would you, and I have yearly blood work, would you suggest I ramp that up a little bit?
Any other members with prostate cancer? Is it just one?
Okay.
Your brother?
Yes.
Then I think one a year is
1
adequate.
year, okay.
Mm-hmm. But if there's any uptrend, then then you start going to at least every 6 months and sometimes quarterly. Okay. Well, thank you all for coming.
Thank you.